Good morning, everyone. Welcome to the Mental Health Coordinating Council webinar on primary health networks. This is the second in our series of sector development webinars. And my name's Carmel Tebbett, and I'm the CEO of the Mental Health Coordinating Council. I want to thank everyone for attending this webinar at what I know is a really busy time of the year, but we've had over 100 people register to attend. So it shows that there is great interest in this series of webinars, which is looking at the services and organisations that make up the mental health service system here in New South Wales. I want to begin by acknowledging the traditional owners of the land that we're standing on. For me, that's the Gadigal people of the Eora Nation, but of course it will be different depending on where you're zooming in from. I'd also like to acknowledge people with a lived experience of mental health condition and their family and carers, and thank them and acknowledge the contribution that they have made to mental health reform, both in New South Wales and across Australia. Now, we have two guest presenters today, and I want to thank them for joining us. We have Anita McRae and Leslie Pullen, and I will be introducing them in a minute. But before I do, I just want to remind people that there will be time at the end for questions. So please put your questions in the Q&A box, and I'll be keeping an eye on that, and we'll be able to put those questions to Leslie and Anita after the presentation. So as we all know, primary health networks, or PHNs, are now playing a very significant role in health across our nation, but particularly in mental health, both through the development of their mental health and suicide prevention regional plans, which have been a big focus of activity over the last couple of years, and also through the commissioning of mental health services. So we're very fortunate today to be joined by two presenters from Primary Health Networks, and I'm going to introduce them now. They'll appear on your screen. I will disappear off your screen after I introduce them while they do their presentation, and then I'll come back at the end for questions. So first of all, we have Anita. Anita is a senior manager with the Mental Health, Drug and Alcohol with Murrumbidgee Primary Health Network, so regional representation. Anita's mental health career started with support work and community development before moving into management positions. Anita chairs the New South Wales ACT PHN Drug and Alcohol Network and is also on many advisory bodies and steering committees, including with ACON, the New South Wales Mental Health Commission, the Special Commission or Special Commissions of Inquiries, and UNICEF. So welcome, Anita, and thank you for joining us today. And we also have Leslie Pullen, and Leslie is the Mental Health Manager at Central and Eastern Sydney Primary Health Network, where she's responsible for a number of programs in the not-for-profit sector that support vulnerable people to access affordable quality primary health care in a community setting. Leslie worked formerly with South Eastern Sydney Medicare Local and the St George Division of General Practice. And Leslie's current focus is on mental health for older people and suicide prevention. And welcome, Leslie, and thanks for joining us. So I'm going to disappear off screen now and hand it over to Anita and Leslie, and I'll come back on at the end for questions. Thanks.
Beautiful. Thank you, everyone. Just let me, of course, work out the tech here. What would it be, a Zoom meeting without some tech issues there? I'm just trying to get my screen so that I can see the slides. Beautiful. First of all, thank you very much for having Leslie and I here today. It's really great that people are wanting to know what the primary health networks are and how we support the mental health of our communities. So please sit tight, and Leslie will take you for a bit of a whip around PHN land. So there's 31 PHNs nationally. We were established in July 2015. It seems like yesterday, but also quite a while ago. So it certainly has been a learning curve for us moving into the commissioning world. And we're really lucky to be working with so many of the providers, some of which who are joining us today. So the two key objectives for PHNs is to increase the efficiency and effectiveness of health services for people. There's a really particular focus on people at risk of poor health outcomes, and also around that improvement of coordination of care, ensuring that people receive the right care in the right place and at the right time. So to achieve these objectives, we're aligned to local health districts. And when I say aligned, we work really closely with them. Some of us are lucky enough, Murrumbidgee, where I am, we have the same boundaries as our local health district. Not all PHNs do. That can make it a bit trickier with multiple local health districts in the PHN footprint, but it's really around working alongside as really key partners with the local health district so that we can improve that frontline service delivery and that integration of primary, community and secondary sectors to try to really make a person's journey of care one that is as smooth as possible. We know people go through the different areas of the health system with their care, and what we try to do is help to support that journey. Really there, we did as Medicare locals, which some of us were before the change to PHNs, really actively engage with our general practitioners and health professionals, and also the community through local level structures to identify and respond to those local health priorities and establish care pathways, and really around that monitoring of the quality and performance of services. And the way we do that, and we try to do that, is to work with the providers in supporting you to provide that care, the highest level of care. So that's a key role for us, certainly as a support function for the providers that we commission. And then really that part of that collaborative work with the local health districts is to reduce those try to reduce hospital admissions and readmissions. How can we keep people better in community where there's a lot of people who can receive their care within the community and in that primary care sector? So what can we do, I guess, to upskill and support GPs and the primary health services to keep people well in community? And people do need to go into hospitals, of course, at times, and it can be around really supporting that care back out of the hospital settings if it's required. So you've got a list there of the New South Wales PHN. So there's 10 of us. And so we work really closely together, and part of the network, one of which I'm the chair of, the ACT PHN is involved too. So a lot of the work that we do together as a network, and we do it on a national basis as well, but it's really key, state by state, we have probably more opportunities to work together and the networks are established. So part of that can be really around collaboration and working on projects. And one that would be, I believe, of particular interest to this audience is how do we minimise the reporting burden for providers? A lot of you sitting out there will be receive funding from multiple different sources, including multiple PHNs. And how can we make sure that our reporting is aligned so that you guys have the time to deliver the services more so than spending a lot of time with the reporting? And we know reporting can be burdensome. We all know it's really important to demonstrate the work that's happening and really to gain ongoing funding. So there's certainly reporting requirements the department who funds us has that we need to deliver. So that needs to be passed on to the providers. But if there isn't a good reason for some of the reporting, then we try to minimise that and make it as easy as possible for service providers. And our priorities are not just mental health, obviously. So listed there are the 7 priorities identified by the Department of Health for PHNs to focus on. And we receive funding from the Department of Health to address these priorities. So there can be quite a bit of crossover, but they are separate funding streams, which have separate requirements there. And so here we have there the role of the PHN around sort of those key focus areas of, service improvement, identifying local needs and gaps, and working with our partners to address these. In particular, through practice support, we work closely with the GPs and other health professionals to build health workforce capacity and the delivery of high quality care. We know that especially in regional rural areas, we have some really significant workforce challenges. So, that workforce retention is really important, not only the development of workforce. There's a lot of investment within that can be financial investment, but also really just working hard on the ground of trying to build and develop our workforce and keep them engaged as well. We've got their system integration. So we work collaboratively within our regions to integrate services at the local level to create a better experience for people with better coordinated care and encouraging the use of health resources and eliminate service duplication. That local, you will hear local said a lot, and that was really why there was the development of primary health networks, so that the Department of Health wasn't sitting in Canberra making these decisions around what local areas need. So it really is around us doing our health needs assessments and letting those local needs drive what our work is. Finally, based on needs assessment and co-design principles, we commission those health services to meet those identified and prioritised needs for people in our regions and to address identified gaps in care. Sounds easy, simple, and look, and it is around, we all have sort of funding restraints. We would love to fund absolutely everything that people knock on our door and tell us about. There's some amazing things out there. There are some restrictions, but it really is around those local needs and commissioning high quality services to meet those needs. So we've got here the mental health suicide prevention regional plan. So some of us also have drug and alcohol included into those plans. It wasn't required by the department. But really, it's around Commonwealth, state and territory governments being committed to supporting joint regional planning for that integration of mental health and suicide prevention services. And most people in the audience would know that this is a key and the first action out of the 5th National Mental Health and Suicide Prevention Plan, the 5th plan. So governments require the local health networks, local health districts, we're talking the same things, and primary health networks to jointly develop and publicly release these plans. They were due by mid 2020 this year. However, due to COVID, we were given a 6-month extension. So this is the month that they're all due. And look, PHNs are at different stages. Some did theirs very early on. Some are, midway through that implementation of the plan. We all know that the development of the plan was actually the easy part. It's the implementation that really takes some resourcing and really careful planning and work with community. So yeah, we're at different stages, but all of the plans across Australia will be delivered to the department by the end of this month. And these plans really provide a regional platform for addressing many of the problems that people experience with lived experience of mental illness and or suicide, and also their carers and families. So, it can include things such as fragmentation of services, pathways, gaps, duplication and inefficiencies in service provision, and really a focus on person-centred care. You're nearly done with me, you're nearly to Leslie, and then she has got the most exciting part of the presentation, so hopefully you're still awake for that. And look, here we have, it's a commissioning cycle. It's not just put out programs, do your health needs assessment, put them out, set and forget. That's definitely not what happens, and this cycle continues to go. So really the regional health needs planning is central. around that local responsive needs-led addressing health gaps. And we have a look there really around that evidence-based programs and at least evidence-informed. We certainly don't want to, we want to take some really forward steps also in our service delivery, and data really sits behind what we're doing there. And I know that Carmel and Leslie and I had a quick chat earlier and really talking about the importance of evaluation and really focusing on that impact and evaluation against what the desired outcomes were. We have seen that in the Productivity Commission around evaluation. So we understand the importance of it, everyone does, and we work hard to include evaluation in our commissioning cycle. When we do reviews and redesigns sometimes, which is what happens as we mature and as services change and whatnot, it's certainly not about throwing the baby out with the bathwater. It really is around ensuring that there's continuous improvement, but that we're supporting that workforce through any of those changes as well. So that's it from me, setting the scene, and I'll hand over now to Leslie. And I'll try not to forget I'm changing the slides, Leslie. You can nudge me at any time.
Thank you, Anita. And thanks for that good overview of what we're doing. And we thought that you'd be interested in exploring some of the questions around how we commission our services and, you know, what the elements are around that. And one of the ones is around co-design and lived experience involvement. So this is one important aspect of, you know, the work we do in being able to make sure that the services that we are going to, you know, pay money for are going to meet the needs of the people they're designed for. So therefore you need to have some input from people with lived experience at every step. And that includes starting from understanding the needs, so the needs assessment. And then it also includes the co-designing of the program. So while we might have some parameters around the sorts of services we need to design, you know, there's still definite input that we can have to ensure that they're going to meet the needs, that they're accessible to the people that they're designed for, and they, you know, address whatever their issues might be in accessing services and having the service delivered to them. Lived experience also plays a big role in our advisory groups across our PHN, and that includes mental health advisory groups, alcohol and other drug advisory groups. It also includes potentially, I know in our PHN and probably Anita's as well, is the Aboriginal and Torres Strait Islander groups, you know, and depending on, you know, the demographics of each of the PHN region, there may well be other people of lived experience that are included in those sorts of groups. And of course, the regional plan working groups that, you know, that Anita talked about, the regional plan, our PHN is coming to the end of the first year of implementation of the regional plan, and our approach has been to develop working groups around that aspects of the regional plan, and each of those working groups includes lived experience as well, because while we're working with our local health districts and community organisations, you know, we need to really have at the centre the people for whom the services, you know, are for. So therefore, lived experience is important. And there's also a national PHN lived experience network. And the purpose of this network is, you know, to enable, you know, on a national level to create an environment that supports not only lived experience and co-design with commissioning, but also, you know, supporting PHNs to actually engage with lived experience. They give advice, you know, to all PHNs to support that sort of work that we do. Next slide, Anita. Okay, so another thing that's of interest is, you know, what's the PH role in, you know, care coordination? And I think this is an important one to explore. PHNs are based in the primary care sector. That is the first line of entry into the health system. So we're talking about primary providers, including the GP and allied health, who are the first line of entry into the health system. At the centre of primary care is the GP, whose training facilitates a holistic understanding of health, and that's physical health and mental health. And so our focus is to support individuals engage with a GP so that they can have, you know, the GP's got a good understanding of what that interconnection might be of the physical health, mental health and social health of an individual. And the GP's role will be then to communicate with these other providers, the specialist care, the mental health services, the allied health, psychosocial services, to be able to ensure that there's care coordination for individuals. There's also, I guess, the choice that, you know, some individuals may not want to, you know, have their GP involved with their care, and there are other primary health clinicians who may fill this coordinating role. But I think one of the key issues for the GP, as well as any other person who might be coordinating, is the communication, ensuring that all services and are communicated with, that the individual is understanding of their care so that they're sort of in control of their care and have a say about what choices that they might have in their care. And I think also to be able to engage with their families and carers if they would like to have their families and carers involved. Another question that comes up is, you know, what is the PHN's role in accountability, outcomes and evaluation? And I think Anita's really gone through this quite well, but just noting that it is part of our commissioning cycle and monitoring and evaluation. And as we're maturing as PHNs, this may well be a little bit more robust than it was potentially at the beginning of our commissioning experience. So monitoring and evaluation really starts with our health needs assessment and our planning about what we're going to be doing, you know, co-designing our project or our service delivery, and in that designing, having a bit of a, you know, like a mapping out of what the service is going to do, what sort of inputs are we putting into that service, you know, in terms of, you know, funding, the sorts of clinicians or workers that might be working in the program, what sort of data do we need to collect, what sort of technology are we going to use, you know, what sort of measures in terms of individual outcome measures, like, you know, their mental health symptoms and those sorts of things, and symptoms or measure of, you know, how individuals might be functioning with those symptoms, you know, perhaps at the beginning of their entry into their episode of care, you know, towards the end of their episode of care, and also how people might be experiencing the service that they're going to, that they're receiving. These are the sorts of things that we map out, so that then that gives us a bit of a basis of, well, how are we going to evaluate? Do we meet those? Did we deliver a service as we proposed to have it set up? Was it set up exactly as how we mapped it out? Was there, you know, measures of outcomes as to how a person improved their symptoms and their functioning after the service? So did we actually meet those needs? And we will prescribe some data requirements of services that are being provided so that we can sort of measure what the changes might have been over time to meet consumer needs. I guess one of the most important things is that when we commission a service, it's not just, okay, here you go, deliver the service and that's it. It's more about a relationship with the provider that's delivering the service and the PHN and any other stakeholders that might be involved in and out of the service, to ensure that we're growing and that we're learning about what we're doing and that the service is actually meeting the needs of the consumer. So we will be having regular conversations with our provider to look at things. We'll be asking for reports on how they're travelling in terms of their activities, and then we'll be measuring how that's going and thinking, do we need to make any changes or improvements to the service to make sure that it's actually, better meeting the needs of the consumers. So what is the PHN's role in community health literacy, prevention and early intervention? One of the most important aspects of delivering a service and commissioning as a service is that it is part of a stepped care approach to supporting the needs of the consumer. And what do we mean by a stepped care approach? It's about assessing a particular individual's needs and identifying where they might benefit most from a service. Do they need some, low intensity type service for their needs, or would they benefit at this point from, something a bit more intense? So it's about meeting wherever the individual might be and providing a service that matches those needs. It's not about, starting at the bottom step and then climbing up the steps, to get to where you need to be. It's about understanding what the individual needs are of an individual and then linking into the most appropriate service to meet those needs. So PHNs will be commissioning services based on a step care model. So they'll be commissioning low intensity type of services, services that address moderate levels of mental health needs, and services that identify and support people with severe mental illness. And they'll also have access, the providers will also have access at any point in time for crisis support and referrals into state-based or secondary services if the need comes up. For the individual. So it's about meeting the needs. So health literacy fits into that role of being able to, have the world population or the population that may be at risk accessing information about mental health and accessing potentially prevention services and being identified early so that they can access early intervention services. PHNs do this by having information on their websites, but also timely information about appropriate services for referrers to the PHN's mental health services, such as GPs, other allied health. There may be other support services, such as, if we're talking about young people or children, it could be school counsellors that are referring. If it's, parents in the perinatal period, it could be early childhood nurses that are referring. So it's about timely information about support services available as well. The next one, I think, Anita. So these are the principles that the New South Wales PHNs developed together so that we could really have an understanding about, well, when we're talking about step care principles, what do we actually mean by that? So we came up with 10 principles that would apply, and you'll be able to see those there. Match to choice and needs, so flexibility to adapt to change. So the needs of an individual might change over time. For example, somebody might be coming in and at the time of their entering the service, they might only need low intensity services, but things may deteriorate, something happens, things may deteriorate, they need to be stepped up to another service that, delivers a bit more intensity of service. It could be the other way around. They may well have come into something with, quite, intense services. They've improved really well, and they might be stepped down to something that's a bit more low intensity services. So it's about having the flexibility to adapt to those changes. The person-focused referral in terms of gathering information into a service so that a person doesn't necessarily have to retell their story. So it's about having our referral forms and information gathering in one central place so that we can be sharing that with the service provider, so that they don't have to retell their story, and make it a bit more of a streamlined entry into supports. I think it's also important to have service options, so that whatever the goals in towards recovery focus plans might be, that the individual has a choice of what sort of service option they may be provided. And it's important to engage a person in organising their particular care plan, so that they have input into their own care and make decisions about who's also involved there. So families and carers definitely need to be supported in there if the individual wants their family and carers involved in their care, which is, it's often important, especially if we're talking about, young people or older people, really about anybody in any time, but particularly for those, that need to, have their parents involved, those sorts of things. So probably some of the if we move to the next slide, Anita, some of the programs that you may well have come across, or where you might be finding that you're working in, is as support workers, might be some of our commissioned psychosocial services. And there's been a number of development around psychosocial services with the NDIS coming on board to support those people who may be experiencing severe mental illness and therefore having reduced psychosocial functional capacity to be able to support and need a bit more support. Now, the NDIS, we know that supports people with severe mental illness, and for those people who have been tested for the NDIS and find that they're not eligible, PHNs have been funded by the Department of Health to commission programs that can provide individual and group support to focus on people, building their capacity to do such things as, improve their social skills and friendships, their family connections, managing their daily living needs, financial management and budgeting, finding and maintaining a home, vocational skills and goals, educational and training goals, maintaining physical well-being, and managing substance use issues, and just basically building broader life skills. So these services may well be some of the places that support workers that are attending today might be working in. And this is where the support worker really has a crucial role in supporting people with, severe mental illness. PHNs have also been asked to support those people that were previously supported by in the community sector under such programs of FAMS, day-to-day living, and there's another one that escapes me, but it'll come to me maybe. And they're who have been assessed for the National Disability Insurance Scheme and have been found ineligible, but were being supported by those programs. Partners in Recovery, that was the other one, have been supported by these programs, and so they are being supported by a program called Continuity of Service. The next one is about, what's the PHN's role in older people's mental health? And initially, when in our funding from the department, older people's mental health was not a specific focus, but in the beginning of 2019, we were commissioning out some support services for older people living in residential aged care facilities. Mental health services are not routinely available to people in these facilities because they're not able to actually access those mental health services that are available through Medicare under the Better Access to Mental Health scheme. And so there was definitely a need for some sort of support for older people living in aged care facilities. So PHNs were asked to commission some psychological treatment services targeting the mental health needs of older people. And these services are intended to enable residents with mental health to access, the same type of services that the people in community can access through Better Access to Mental Health, which is funded through Medicare. So these services, target people who primarily have mild to moderate symptoms of mental illness, and this could be, depression or anxiety, or, those people that might be at risk of developing these sorts of mental illnesses if they are not receiving treatment in the next 12 months or so, and it's about getting access to timely services. And in response to COVID, there was identified need for older people who have been disproportionately impacted by the physical and the social distancing measures that have been put in place to manage COVID, being that older people are at risk, at a higher risk than the general population of adverse outcomes should they contract COVID. And they've been isolated and had a lot of loss of support from family, friends, and other community services that you might be involved with, where they might, have had to cease services and may not have yet been able to recommence those services. So PHNs have been asked to target older people in their region who might be at risk of mental health issues because of these restrictions, and whose physical health is not being addressed because their older people have been reluctant to go outside or go and access service or even go and see their GP. This funding is targeting people over 65, or in the case of Aboriginal and Torres Strait Islanders, over 55, either living in the community or who live in aged care facilities, depending on the needs of each of the PHNs and what services they've already commissioned. This might be just an enhancement of a current service, or it may well be something that needs to be engaged fairly quickly, because it's only a time-limited 12-month funding service to support those people. And probably you might be interested just briefly to understand PHN's role in the commissioning of drug and alcohol services. So PHNs are funded to increase the capacity of drug and alcohol treatment sector and achieve some improved health and social outcomes for individuals, families, and communities at risk of or currently affected by drug and alcohol use. And of course, PHNs do this through improving local service coordination and targeting areas of need. PHNs also do a needs assessment around drug and alcohol services and needs of individuals, so that they can, bridge the gaps and better meet local needs and work collaboratively with stakeholders, so that promotion of quality improvement approaches and support for the drug and alcohol workforce as well. And lastly, just a little bit of information about suicides. Now, you may or may not be aware of the New South Wales priority around towards zero suicides. There has been an investment of 87 million over 3 years and is a priority of the New South Wales Premier to reduce those suicide rates in New South Wales by 20% by 2023. And there has been a number of initiatives that are being funded by New South Wales Health to support that. And these include, listed on the next slide, Anita, some alternatives to the ED, emergency department, some suicide prevention outreach teams, and aftercare support. This is a bilateral agreement with the New South Wales Ministry of Health and the Federal Department of Health to be commissioned by PHNs, which is the Wayback Support Service, which offers care coordination to people who may have attempted a suicide or be experiencing a suicidal crisis. And that's being slowly rolled out across not only New South Wales, but across other states and territories with support by their state health department. New South Wales Health have just granted a funding agreement to do a youth aftercare pilot. So while the Wayback Support Service doesn't have really any limits on age, young people potentially need something a little bit more focused on their needs. And so New South Wales Health has commissioned a youth aftercare pilot. So we'll be interested to see how that goes. And they're also building resilience in Aboriginal communities. And there are a few other individual activities that are being commissioned, which you can see on their New South Wales Health's page. If you just Google New South Wales Health towards zero suicides, you'll be able to find out that information. So I think that just gives a bit of an overview of the flavour of the sorts of things that we're doing, and a little bit of detail here and there. So I guess we'll open up to questions now.
Great. Thanks very much, Leslie and Anita. That was a really helpful description of the role of primary health networks. And I think some of that detail about the areas that you're working on, care coordination, the commissioning of services, I think particularly psychosocial support services. I know a lot of the participants would be working in that space, was really very, very informative. No shortage of work for the primary health networks. I think we could deduce from that presentation a lot happening, a lot you're involved in, but certainly if it can help people get the support they need when they need it in communities, then that's something that we're all signed up to and want to see. So great opportunities, I think, there to work with the primary health networks. Now, there have been a few questions that have come through the question and answer box, but can I encourage people to put their questions in the Q&A box, because Leslie and Anita have indicated they're willing to answer questions, and now's the opportunity. And I should just say that there's also some very positive comments in the chat box about your presentation, both Anita and Leslie. So people, I think, have really valued what you've had to say. So thanks very much. Okay. So there's a question here from Darren. Are all PHN consumer and carer design committees involved in the national group? Are PHNs required to do this? Now, I'm not sure who might want to answer that, from Leslie or Anita, or both of you, but you're both on screen now, so you can both talk, and I'll mute myself while you answer.
You can go
Okay.
first, Leslie.
It's a good question, and I'm not 100% sure of the answer. I know that quite a number of PHNs are involved with the national group, but whether they actually have their, I don't believe that they necessarily have their co-design committees involved, but there will be a representative from the PHN. Now, whether that's a representative of, the mental health teams within the PHN, or whether it's a lived experience representative, or both, I guess it depends on the capacity of each particular PHN to participate. Did you have anything else to add?
I was just going to say, broadly, we're mandated to, and rather, even if we weren't mandated to, certainly to involve consumers, carers and lived experience in everything that we do. And it's really important that there are some established networks locally, and ensuring that our connection and with people with lived experience is genuine, and that it's where possible, it's not overburdening as well, because I think being mindful, and we pick up on that with our local communities and connections. So it's just really being mindful of a few different things. But certainly the government who funds us, the federal government, does want to see consumer care engagement. And more importantly, we want to do it, and we know the value of that and the importance of that in a respectful and careful way.
Great. Thanks, Anita and Leslie. So another question, 5 years on after the establishment of the primary health networks, what are the things that you would say are working really well, and where do you see some of the challenges, I guess, particularly in the mental health space?
I think we've grown and matured as commissioning agencies. So right at the beginning, it was, bam, you need to commission services. We didn't even, we had to learn fast what commissioning of services really looked like, and there was support for that, and there was certainly some expertise that we all brought in and did as well as we could at the beginning, knowing what we did know. Some were Medicare locals that turned into PHN, so some of us had been really delivering these services before, so certainly brought that knowledge along. But I guess really fine-tuning that local needs driving what activity we do. And within mental health, we know, and everyone who's attending this webinar know how noisy the machine of mental health can be, and how important it is that we make that as accessible, the services as accessible as possible, and we're really keeping that noise to the background. Ensuring that health literacy principles are across the board, so that access is by all the different meanings of the word. And I think we've come a long way in refining that. And we need to continue to work with our communities and listen and take on board feedback. And with our regional plans, all of them go out for public consultation and feedback. It's a key document. I think there's always improvements in mental health, and a lot of the time it's relationships. And we can't be just dependent on individual relationships. We need to work harder as a whole of system of how to embed and have more of a strategic and system that works regardless of who's where. So I think that's something we all need to work on together. Great,
thanks. Leslie, did you want to add anything there?
No, I think Anita covered that really well.
She certainly did. She certainly did. So there's another question here about whether there's any collaboration with the Department of Education around supporting youth mental health. Now, you would be aware just in the last budget, the New South Wales government have announced the nurses, wellbeing nurses that are going to work in schools with a focus on mental health, although not solely on mental health. But yeah, the question is, now it's not clear from the question about whether it's collaboration, but I assume from the primary health networks with the Department of Education. Certainly at, I think, the LHD level, there is that collaboration. But anyway, over to you.
That's a good question, and I don't know that I can answer the question on behalf of every single PHN in New South Wales. We don't have, and in our PHN, we don't have a direct conversation with the Department of Health around youth mental health, but PHNs actually commission the Headspace centres within their region. And the Headspace Centre's remit is to definitely work with schools and support of young people. So there'd be definitely work, happening there as part of our overall monitoring, contracts with our Headspace Centre. So that's a definite place where we'd be working with the department through the Headspace Centres with the Department of Education. Anita, do you?
Yeah, so I think it can depend on in different areas as to what the needs are. So I know that we certainly do in the suicide prevention space and the broader mental health space, and really a lot of that work is focused. So it's what bubbles to the surface that needs that support, and we can take on that role of supporting those the people who need to be linked together to solve the problem that's come up. So say, for example, it's around that care, that supporting of care for a young person who's in school that needs to go into acute care and come back out and be re-engaged with the school. And there were huge issues in our area around that, which ended up with sometimes kids being suspended from school when they returned because there was a lack of care plan sent out, or there was, some, and for a kid that's been into acute care, what a terrible experience to then be suspended. It was no one's fault. It was a system issue. So we were able to coordinate getting the key people together, health and education, as well as Headspace and whatnot, and really look at some of those wicked problems and trying to nut those out. So I think we have touch points with Department of Education. It's really important that they're a key stakeholder. And what I guess the different types of work can just be around those local things that bubble to the surface.
Thank you. Thank you. So another question, do PHNs have the tools/authority to anticipate population needs and respond accordingly, rather than solely responding once issues are already embedded? And they're particularly interested in terms of the health repercussions of 2020.
Yeah.
Big question, but a good one.
Yeah, it's a fantastic question. So some of us have certainly staff on board who are very, look, there's a word for them, and it's my roommate, and she'll kill me if she hears that. I can't remember what she is, but certainly a data guru that can really look at overlaying all the different data sets. So, Australian Institute of Health and Welfare, some sort of crime stats, and all different. There's so much data, and pulling it together in a way that can help us to prioritise. So I'm not quite at the answer to that question. So there's a lot of work that goes on in the background there. But in regards to 2020, the year that has been, we certainly look at opportunities we engaged Three Rivers University to do, a rapid literature review around what are the implications of the social distancing measures that happened, and how can we be on the front foot so that when we did receive funding, we already had mapped what those needs for different community members are. So whether it's our LGBTQ community, it's our older people, it's our farming communities, it's so that we can be as quick off the mark with evidence-based sort of a stand to move from, so that we can move quickly. It is a really good question, and it is really difficult. We want to be much more proactive than reactive all the time. I don't know if Leslie, you wanted to add something there.
Look, I think the relationship that PHNs have with their service providers, in terms of those providers that we've contracted to deliver services, they're on the ground, seeing what's presenting to them, or, you know, even just such things as service demand or the types of presentations that might come to their service, can quickly, you know, determine, you know, there may well be an unmet need about something, rather than wait, as you say, for it to be embedded and then, you know, what can we do about it? Then we could be chatting with the service provider. Is there something we could be doing differently? Or is there any, you know, other little buckets of money that we might have that we might be able to, you know, support a different, you know, a complementary program or something a little bit different that might add to that service to support whatever the needs might be that are coming up.
Great, thank you, both Leslie and Anita. So we've probably got time for maybe one or two more questions. There's one that's come in from Lauren. Do you see the privacy between consumer and family carer, as understood by clinicians, as being prohibitive to engaging a lived experience peer workforce, i.e. often it's easier to say you can't divulge information due to consumer privacy, rather than encouraging an open dialogue between the three parties. This causes much distress overall. Do you see education on this likely? Now, that's a really big and important question as well. I don't know, Anita and Leslie, you might be able to comment on that. It's not necessarily directly, I guess, in your area of responsibility, but it is one of those issues that comes up time and time again, and that is, you know, the role of privacy legislation in sometimes inhibiting the kind of conversations that need to happen.
I think it's really important. Privacy is, there's legislation, and it's important that people's privacy is respected, and that that legal requirements are upheld. But I think what is being referred to there is really an experience that a lot of people have, where it's used as a blockage, and it's used as, it actually inhibits care, good care. It also can mean that, and we hear time and time again around, people don't want to tell their story over and over again. That can be distressing. There's so many things that if that privacy is used as it's intended to be used, and not as an inhibitor to really good, comprehensive and coordinated care. It just really needs everyone, it needs to be put on the table and discussed within your regions as to when it does come up as a problem, because I know we've worked on an integration project around a common sort of form that will cover off on a lot more of that privacy kind of blockages, and the person needs to be at the center. They need to have the control over that. And I think peer work was included there, and I think there's a lot of work that needs to be done there about demonstrating the value, the absolute value of peer workforce. It cannot be underestimated, and there's a lot of clinicians who we need to work with so that they can understand and appreciate the value that is provided there. Leslie?
That's what I was going to say to Anita about, you know, the demonstrating or having an understanding, clinicians having an understanding of the value of, you know, the peer workforce.
Great. Well, look, it's just nearly 12, so I think we will bring the webinar to a conclusion. We will share the slides. Leslie and Anita have agreed that they're happy for the slides to be shared, so we will share that with all participants. We'll also record the chat function. We'll make sure that that information is shared with Anita and Leslie. There's a couple of questions that we haven't been able to get to, but we'll try and deal with those after the webinar. But can I just thank Anita and Leslie, both of you. You've been so generous and knowledgeable, and I think this relationship with primary health networks is just so important. And so to have the opportunity to hear from you and for people to benefit from your wisdom, and I can already see it coming through in the chat, people saying thank you, thank you. So really appreciate your time. Please, to everyone online, we will be doing webinar number 3 in the new year, and it's got a focus on GLBTQI issues, so keep an eye out for that. Thanks, everyone. Can I wish you all the best for the festive season? Look forward to seeing you in the new year. And in particular, thank you to our presenters. Thank you.
Thank
See you
you.
all.
Thank you.
Bye-bye.